A pleasant good evening to you, our listeners and our viewers here in Anguilla, throughout the diaspora, and throughout the globe via the various media methods. Let me take this opportunity to welcome you once again to another edition of Just the Facts. But before we start, I will ask Mr. Webster to open us with a word of prayer.
Sure. Well, let's bow as close. Dear God and Heavenly Father, we give you thanks for your mercy and your grace. We thank you, dear Father, for your blessings, your love, and for the life that we can be here, dear Father, in this program. I know, dear God, that health is one of the ministries that you started on earth, and we will do our very best, dear Father, to continue your ministry here. I pray that you will bless the hands, bless the persons that are working diligently, and those who are still at work now, to continue to provide the best health care for the land of Anguilla. Be with those persons making decisions, dear Father, for us. Pray, dear God, that you will bless us as we continue to move forward with healthcare in Anguilla. Bless each individual family represented here in our households, and continue to bless us as a nation. In Jesus' name I pray. Amen.
Amen. Thank you, Brother Malcolm. This evening we have in studio is Dr. Sherlan Richardson. He's the Director of Medical Services. And we have Mr. Malcolm Webster. He is the Health Services Commissioner acting. I would have mentioned on the program before that the aim and the purpose of this program is to inform people here at home and abroad of what is happening in government. And as you know, government is made up of several portfolios, ministries, and departments. I would have said on a number of occasions that we were reaching out to, the deputy governor and the governor because they are responsible for the civil service. And while Just the Facts may be viewed as a political program, so to speak, the essence of it is about information and dissemination of information to the public with respect to what is taking place in the various departments. I would have indicated that I intend to invite the deputy governor here so that we can talk about the civil service in general and what his portfolio entails. I would have indicated that a number of department heads and permanent secretaries will be invited as well. It's not mandatory. It's voluntary. And seeing that I have been tasked with the responsibility for healthcare, I thought it fitting to invite Dr. Richardson and Mr. Webster on this program, and they are the first civil servants to be, I wouldn't say interviewed, but to have a discussion with respect to healthcare in Anguilla. There is no doubt that healthcare, not only in Anguilla but throughout the world, faces a lot of challenges. We here in Anguilla, we have our share of challenges as well. We have our share of criticisms. I would, from time to time, get a ton load of calls, and I'm sure that you all would get some of the same calls as well in terms of issues surrounding the delivery of healthcare, the attitude, style, and approach of some of the employees, and so on and so forth. And on occasions, I hear quite a bit about the positive things that takes place within the services as well. So we're here to have a discussion about, both positives and negatives, the do's and don'ts, and where we need to go in improving the quality of healthcare services. So I'm going to start off, Dr. Richardson, with you. As the Director of Medical Services, and I believe that you're not a year in this position as well.
No.
Not as yet. But you're no stranger to healthcare services in Anguilla. Coming back, you've been here now probably more than a decade.
Yeah, 15 years plus.
15 years plus being involved in the healthcare system. I want you to sort of tell the listening and viewing audience, in terms of the Department of Health Services now. We will talk a little bit about, because you are also part of the Health Authority, and now part of the Department of Health Services. Where we are in terms of what is available in terms of services from a medical standpoint up at the hospital, because there's a notion out there that there are some areas that are not being covered, and so on and so forth. So give us a little rundown in terms of the medical proximity and the matrices that are available at the hospital.
Okay, so sometimes it's actually a bit surprising to find that persons aren't aware of some of the things that we offer.
Right.
So for example, our obstetrician gynecologist just relatively recently said that they met someone that said to her, well, how long have you been here? When has the hospital had a obstetrician gynecologist at a clinic? Because she also goes to the clinics. And she answered, I think she's been here already 8 years. And of course, before she was here, we had persons before. So as long as I've known the system, we've had obstetrician gynecologists. We have surgeons. We have internal medicine doctors that deal with diabetes, hypertension, etc. We have a pediatrician, deals with the children. We have anesthesiologists. So when you have your surgery, those are the persons that put you to sleep so that you can have make sure that you don't feel any pain while you're having the procedure. We have family medicine practitioners out in the community. Those are persons that would be versed in seeing persons of various ages, from children to adults, as well as some limited amount of obstetrician gynecology care as well. We have radiologists. Well, rather single, a radiologist. So that is someone that is trained to read X-rays, CT scans, etc., ultrasounds, etc. So we have these services. And another question that sometimes pops up surprisingly is persons might call from the community and say, well, do you have a doctor in the emergency room? And the fact is, we have 2 doctors in the emergency room every shift, and there are 2 shifts. Now, you may go at a time when one doctor is on a break, so there might be 1 doctor there, but there is no point where there is no doctor in the emergency room. I believe in years gone by, it would have been staffed by, this was many, many, many years ago, it would have been staffed by nurses long before I came back, and then the doctor might be called out if need be. That is not the case. There's always a doctor in the emergency room.
Yeah, 2 things you mentioned about the OBGYN and also about a pediatrician and so on. While they are singular, from what you just said, I think we've come of age where not only one OBGYN or one pediatrician needs to be on staff. Where are we in terms of providing that support and that additional specialist for healthcare services?
Right. So it was decided more than a year ago now that the specialty services should not have one person.
Right.
To have one person on call for that service all the time was very onerous. And as someone who was the lone internal medicine doctor for many years, I can attest to that. So right now we're actually trying to get 2 of each specialist in place. So we've had, just very recently, last week, interviews for the pediatrician, and we are to have interviews this Friday for obstetrician gynecologist. Now, how soon will we have that person in? It depends. Because once we have the interview, we go ahead, write our scripts, it goes to the Public Service Commission to review our scripts, and then on to the Deputy Governor before those persons, single person, whatever the case may be, are then approved to be offered the post. And then I say persons because sometimes we have a number of persons that we think would be a good fit for us, well trained, able to work in an environment where you don't have everything that you might need at your fingertips in terms of materials, subspecialists, exactly, technology, everything. And if the first person declines, we have a second person to go to, etc. But the idea is that we should not have a single specialist working at the hospital. Again, it gets very tiring, and it can, if persons are tired, that could be dangerous for them and the patients.
You yourself, during the COVID pandemic, being the only internist that was available at the hospital, and I'm sure you would have had contracted COVID once or twice during that.
I think it was twice.
Twice?
I think it was twice.
So there again, lies the whole notion about having, let's say one specialty that is available there. We've gone past that a long time ago, because I remember the days down at the old cottage hospital where they had Jagan alone, Dr. Jagan, God rest and bless his soul wherever it is, one doctor for the entire island. We've gone a long way, since that. So I am pleased, and I'm sure the viewing and listening public will be pleased to hear that interviews are taking place now. So we are moving in the right direction in terms of getting the healthcare staff, the personnel in place, because it doesn't matter how much we improve in terms of technology. We've got to be able to have those bodies that are there. Yes, in areas where there are 3, 4, or 5, you probably can bring it down to 2 or 3, but you've got to have bodies there. So I'm pleased to know that you are moving in that direction. Interviews are taking place. Of course, you mentioned about going to the PSC, the deputy governor, and public admin, and all that sort of stuff is still there. That could, let's say, prevent the expeditious process in terms of hiring. We're going to come to that a little later on, but you did mention 2 physicians in the ER at any given shift,
yes.
And so on. The general public out there, they're concerned, and they let their concerns known in terms of the waiting time, let's say in ER. Now, all over the world, I mean, you've got to wait. But I'm saying it seems to be more prevalent, or people here seem to think that when you go to the ER, at the end of the day, you need to just go in because I was here before you, or whatever it is. Tell us a little bit about the triage system and so on and so forth. And even during the latter hours, whether it's from midnight until 7 the next morning, what is there at the ER in terms of personnel and how it works.
Right. So when you go to the ER, it's not a first come, first serve system. It's based on triaging, as you mentioned. So what does that mean? A nurse will look at the persons that come in, and then they will class them based on the urgency of their condition. So let's say, for example, someone has had a cough for 2 weeks, and it's not very persistent. It's there, but it's not persistent. And they decide, this has been going on for 2 weeks. It's after hours, let me go and get checked out at the hospital. That person would be seen as less urgent than someone that comes in complaining of chest pain, they're sweating, they're short of breath. That second person would need to be treated more urgently than the first. So even if that person came 2 persons after that first person, if no one else is more urgent, then that person has preference to go in and be treated because they need to be addressed more urgently. So
Also
in that
for
way,
children.
also for children, persons who are in severe asthmatic attacks, for example, they would need to be treated more urgently than someone that comes in with, let's say they've had a cut, but now they've controlled the bleeding already, but they need to get it stitched. Okay, that needs cleaning and stitching, definitely, but that person who has a severe asthma attack must be addressed first. Because one is potentially life-threatening, whereas the other one can wait a little bit to be addressed. Important, but one needs to be addressed more sooner than the other. Now, during the day, we're trying to have a dedicated triage nurse. Presently, that's not the case. Presently, we have 2 nurses. Sometimes we manage to have 3 if we can manage to staff it that way. And that nurse might be in and out of the emergency room. Now, the idea behind having dedicated triage staff is that that person is there. They can see what's happening in real time, and can then better move persons according to the urgency.
So you think we've got a lot of work to do in terms of informing the public, educating the public, in terms of the expectations, coming to the emergency room and so on. You think we're lacking in that area?
I think so, because it always bears repeating to persons when they come in, because when you come in, you're not feeling well, you're not thinking, oh yes, I heard 2 months ago that it goes this way.
Right.
So I think part of just going to persons, speaking to them and saying, okay, we realize that you're here, but we have another case which we must attend to. Your case is important, but we need to take things based on urgency, and just explain to persons based on their urgency, if they're likely to be waiting a while, that they will be waiting a while, so that they are already prepared mentally that might be the case.
Yeah, you mentioned a good point there. At least that communication with the individual who would have showed up at the ER, because we showing up at the ER at the hospital. You're not going to get chicken and chips or a barbecue wings. You're coming there for something. But at least that communication is key to the patient. And most of the time, when you have an individual showing up at the ER, they have family members there with them, whose expectations may be different, and sometimes and does not understand even in the triage system and so on, and feel that all of a sudden the doctors are in there sitting down and sleeping, or whatever the case may be, because you hear that from time to time. Let's be real. At the end of the day, that is something that we have to deal with in terms of the communication, skills with the patients as well as the family members.
Well, we also have to consider, Mr. Rogers, too, that there is the option for when we have Monday to Friday, it's the clinic.
Yes.
And that's one of the things that we're trying to get persons to utilize, to do the uptake, to do more of. In reality, there are things, persons will come to ER for, let's say, a blood pressure check. That can be done at the clinic. You don't necessarily want to be waiting at the hospital for something like that. And so I guess when you get further in the conversation, we are continuing to improve the services at the clinic. And so we want persons to also, if it's something that's non-emergent, something that you've been sitting home with, for example, you can be seen at a clinic as well, simply because we also staff the clinics with doctors as well.
Yeah. Again, that goes back to the communication and information and education of the public, because I've gotten from time to time, calls like, hey, Senator, I showed up at the hospital, they tell me go to the clinic.
Right.
A lot of that without me asking them, what you went to the, because I'm going to the hospital, at least they could have seen me, as opposed to telling me go to the clinic, and so on and so forth. So again, that is we in healthcare, we have to address that, the communication, getting the information out there to the general public that, hey, between 8 to 4, X, Y, and Z at the clinic and so on and so forth. Now, I'm a stickler for training. You mentioned about the various specialties that you will have up at the hospital. That's on the medical side, the nursing side of it now. Where are we in terms of personnel, in terms of filling the vacancies that will exist? Because we all, well, you would know much better than I do, because even though with my limited knowledge around healthcare, nurses and the allied health, they are key. You physicians, you all are the hefties, so to speak, but in terms of a lot of the actual work, the backbone of it is the nurses and the allied health folks and so on. Where are we in terms of the required staff that is necessary? Because we're going to talk about salaries in a little while, but where are we in terms of that?
I can't speak as specifically as Sister Haywood would, but we're getting
there.
We're not there as yet.
Right.
So in terms of, like I said, dedicated triage nurses, do we have anything like that? Dedicated triage persons, we don't have that. We have a person that we're hoping to go off to study emergency room
medicine,
nursing.
Right.
So we have that. We have persons that we want to go away to study ICU care, because we are looking to see if we can have a small ICU unit, because presently what happens is our ICU is wherever we can fit it.
Right.
Yeah.
The
So
closest
if
place we
someone
could fit
falls
equipment in.
ill, we try to
Yeah.
find a single room.
bed
If they need to
space.
be intubated, we put them in there. We have them in a private room.
Okay.
So our private rooms aren't private rooms as they were, say, 15 years ago, where it was for persons that specified they want a private room. Right now, our private rooms actually serve more as
ICUs.
rooms for isolation, rooms for patients that are not doing as well, and we want to keep a closer eye on in a more controlled environment.
So even in the state that we're in terms of limitations in the hospital and stuff like that, you know, I've been saying all the time that, you know, definitely within this 5-year period, I'll make sure that, you know, there is a modern medical complex that will take all of these things into consideration. But be that as it may, you're saying that we intend to establish a small IC unit, whether it's 4 beds, 6 beds, or so on, so that we can have a dedicated space
Correct.
for that sort of
Correct.
stuff.
Yeah.
But
Again, staffing.
But again, we're going to need staffing because
Right.
that area is going to be
Further away from the ward, actually.
slightly away from the ward. And if you have one person there, how does that one person function by themselves? You need at least 2 persons. One person needs to go take a break, whether it's to eat, use the bathroom, whatever the case may be, or if they need assistance with someone, then you can always have one person working while another person goes for help or assist. So whatever the case is.
Yeah.
So therefore, even in that small setup, you would need more staffing to make sure that.
I always get in, I wouldn't say trouble, but you know, some people may think it's an overreach. But when it comes to healthcare, you know, when you look at you know, the census, let's say, of the hospital, the number of beds, you know, knowing how they calculate, let's say, staffing needs.
Right.
You know, it's not based on basically the census at any one point in time. You know, I usually refer to it as the fireman syndrome. It is easier if we intend, and we are looking forward to improve the quality of healthcare services and delivery in Anguilla. And to be able to do that and do it effectively and efficiently, we've got to be able to have the requisite well-trained staff to do it. Now, the folks, the financial folks may look at it differently. You know, they would probably say, well, hey, wait a minute, sometimes you have no one in ICU, you know, so why would you have 2 nurses for 1 person? And then those of us who are involved in healthcare would know, well, within the same 5 or 10 minutes, you can have ICU, you know, with full if you got 5 beds.
Yeah.
What do you do then when you only have 1 nurse?
Right.
Hence, again, you know, the public perception of, hey, you ain't got nobody working, you know, there's only 1 nurse, I can't get this, and so on and so forth. So I am pleased to know that we're heading in that direction. And from what both of you all said, that that area will be away from I
The
guess
general ward.
the
From the
general
general ward.
ward.
Yes.
It means that you all would have identified an area
Yes.
where we
Yes.
intend to do that.
So we're looking at a proposal now because we do have, after COVID, we built a dedicated isolation ward. So we're going to utilize some of the space in the isolation ward to create the ICU.
Your experience in terms of the interviewing processes that are taking place, and you know, the job offers, you know, your shortlisting, and so on and so forth, taking into consideration, you know, the compensation packages, so to speak. You know, you said that you would have interviewed, I think, for a pediatrician,
Yes.
ped sometime, and then on Friday, this
For the
Friday.
obstetrician gynecologist.
Okay, good. I mean, this interviewing process just didn't start this week. Y'all would have been interviewing, I know for sure, late last year.
Yes.
What are some of the experiences? Because the general public and listening and viewing audience need to know exactly what are some of the experiences that you would have had during the course of that.
Well, to be honest, Doc, correct me if I'm wrong. This would be the second time we're doing pediatric interviews for a pediatrician.
The pediatric. Yes, correct.
This would be the second time. We interviewed before last year. We looked at making the offer, that was done, and then the prospective candidate opted not to come. There are a lot of different things involved in actually getting the person to come. or even just the interview process. In reality, it could take about 6 months before we actually have a confirmation that somebody is coming. We do have to also respect that most persons at this level are already working. So you've got to give them 3 months to 6 months to give their employer. So then that adds to the time that person comes to you. Just recently, we did nursing interviews about 2 weeks ago for psychiatric nurses. 3 offers were made and only 1 was taken up. Outside of the room, the conversation isn't not necessarily just about the compensation package, it's about the workload. A lot of persons, like when we interviewed a pediatrician before, they'd be like, okay, well, there's only 1 pediatrician. So that means if I come, I'm the lone pediatrician. In some places, a lot of the larger Caribbean islands, you have multiple people working, so you're not the singular person all the time.
When you talk about that, do they inquire about having private practice? Let's say, for instance, the Purity.
They do, actually, and that was one of the things we actually worked out with the DG, actually moving forward, because that was always the question, like if and when I come to Anguilla, will I be able to, be able to have my own private practice, which we've now approved, so that's no longer a stumbling block. Our hurdle really is the compensation package, and the one thing we can control is the cost of living. People do their research.
I was about to mention that the compensation package is one thing, but then the cost of living in Anguilla, and we can't hide away from it. The cost of living here. If you're going to compare, let's say, to some of the Windward Island, those, further south, there's no doubt about that. The cost of living here in Anguilla is a lot higher than that. And if you're looking further, within the region, they're going to take that into consideration as well. While as low as the salaries are here, you make a few dollars more than what they would make in their home country. Then they'll, it's about rent.
Yes, I was going to say,
which is high.
The conversation comes back to us, Mr. Evan, Mr. Rogers, where we are listening and hearing, and you ask like why you didn't take the offer, and they'll say, well, I looked at what is rent. You guys don't have public transportation, so now I have to get a car. You look at what the cost of food is, and then when I look at what I'm taking home versus paying my bills, and then we have to remember that some persons may have, they have existing families and mortgages and other commitments where they live. So they're not going to leave that commitment to come to Anguilla and then not be able to support their families back home and not be able to see themselves advancing either in the work that they're doing or in their ability to save.
Yeah, well, again, that is an issue, and hopefully, I know that there is salaries review and a public sector reform and so on. A report, whether it's a preliminary report, should have been completed at the end of last month, February. So I am looking forward towards to see what is in that report, basically. And I would hope that there would be an increase, for the civil servants, because, as it is now, there's no more health authorities, so you all are civil servants, moving forward. And I would hope that the Department of Health Services would be included, as opposed to the issues that we were faced with last year, when, I assumed this particular responsibility. So we would hope that we share and share alike, and a lot of the disparities that existed, sometime before in terms of healthcare, that the folks will be duly compensated moving forward, because there's no doubt that we've got to be able to improve the quality of healthcare services in Anguilla. Staffing, training, and that training is not only from a professional standpoint, but that training also is related to communications with the internal customers and the external customers. The perception that is out there, we're not going to be, as white as snow, I should say, but in no areas. But at the end of the day, there must be a significant improvement in the quality of healthcare services in Anguilla. Doc, I'm going to come back to you, but seeing that we have Brother Webster here, you've been doing a lot of work. You've been doing a lot of heavy lifting that the general public really and truly do not know anything about. They are unaware of the amount of thing. And then you have to deal with me, which is again in itself an issue, because at times I could be a little demanding, because I am passionate about, us getting things done and improving on what is there. You're not going to get it totally right overnight, but small steps,
Facts.
moving forward, is what I'm looking at. It is said out there, I heard that you seem to, or I seem to be relying on you, for a number of things and support and so on. And I say publicly, yes. And I make no bones about that, because when calls coming to me, I'm going to call you.
Right.
And I don't hide that in terms of, improving the quality of healthcare services from the technical, professional end of it, and even from the various relationships that we would have established over the years. We would have gone to the DR
Yes.
last year to look at equipment from
GE.
imaging equipment from
imaging.
GE. We would have done our due diligence with Siemens,
Yes.
with Philips,
Yes, we did.
and GE.
Yes.
So we're not just limited to a particular manufacturer. We
Right.
went around and we did what we were supposed to have done.
Right.
This is not a political program. It is just the facts.
Right.
So at the end of the day, we would have secured some funding for some equipment. We would have done the due diligence and stuff like that. But in terms of the visit to the DR and what we were exposed to in terms of the demonstration of the various bits and pieces of equipment, give our listeners and our viewers a little bit of a précis of
Sure.
your thoughts.
So we went to DR, as the minister said, for basically imaging, but imaging across all platforms. So radiology, CT, MRI, and even for oncology. Little did we know, DR is actually leading in equipment, and they have some of the newest and latest G equipment in not only the region, but in this hemisphere. We were able to see, and we were demoed basically the brand new CT, new MRI, as well as the gamma machines for cancer treatment. We were also able to look at some stuff in radiology, looking at the new X-ray, because we want to work with a new fixed X-ray as well as some portable X-rays. And then what we really liked was the ultrasound. And GE has really been keeping pace with the emerging technologies, and AI is a big word that's thrown out now. AI is being used heavily in healthcare. I think it helps the physicians in terms of just having that additional element of information, because obviously AI is pulling from millions of information, millions of bits of information, and then it also makes it easier for the end user. So the ultrasound that we actually saw, is probably something I could use, and I am not I don't know anything about that other than the actual technology itself. But to be able to have the images as precise, to be able to have the measurements precise, and then to be able to present a preliminary report that then the doctor would review is exceptional. We saw the same thing for the CT in terms of what we're able to do with that. And we are looking at the possibility of a new CT for Anguilla, as well as just to see how we can improve imaging throughout the hospital. And one of the things that I think that we did very well, especially after Hurricane Irma, was when we put in the PACS. So we are able now to actually send the images. You don't have to walk from accident emergency to go to X-ray for the doctor to see an image. And then what makes that even more helpful is for telemedicine now, when we have persons that have to fly out, or persons that are looking for a second opinion. We can sit back and email you images and just, at your convenience. And it also means we now have the electronic record system at a hospital. So your record follows you to every location that we have a facility. So definitely the DR was mind blowing, actually.
And like I said, I make no apologies for this. And GE sponsored quite a bit of the
Yes.
of the funding, the accommodation, and so on that was there. You know, the politics would get involved and said you're spending government money left, right, and center, and all that sort of stuff. But be that as it may, whether that is so or will be so, I have absolutely no apologies for spending the money in order to be able, so that we will be aware of what is taking place over there.
Rogers,
You did mention in terms of training and telemedicine and having the electronic record system and so on and so forth, and that put me to the next question. There is some training, what's called evident training.
Yes.
What is that?
So we're actually doing a twofold system. We're going to attend. I have 8 persons from across the various divisions of the hospital. We're going to attend a conference in Dallas.
Only the hospital?
No.
Or do you have
Yes.
financial folks in it?
Yes.
Folks from the Treasury? I mean, across government?
It's across government.
Okay.
So we have those going to that, and then what we're planning to do is we want to do a relaunch of our electronic health records, retrain everybody so that we can start from ground zero. What we've realized is that and we've known this for a while, there's a lot more that our electronic health records can do. Because we're now with the ministry, where we're actually trying to do more things. We're developing registries for diabetes and hypertension, etc., which is going to be very helpful for you going forward, because I know you're working on a program to assist with diabetes and hypertension, and then having that information electronically that we can be able to present, who the patients are, what drugs we're using, those type of things is going to be good for us. And we realize there's just a lot more that our system could do that we aren't using. And so we want to train everybody so that we're not. One of the issues we had was we rolled out in COVID and we didn't have the time to train people properly.
Oh, the evident training was rolled out during COVID?
Yes. Okay. So that was actually at a time when Angola was in a bubble. And we had already committed to them coming. So they ended up in the bubble for, 2 weeks, 10 days, the incubation period. And then the rest they had was for us to train on the ground, which actually shortened our training time to about a third.
Okay. So in terms of training and using the technology and the telemedicine and stuff like that, we're on our way towards that. The electronic records. If you go to the Valley Clinic and they pull up my date of birth and my name, they'll be able. The doctor will be able to.
So if you came to the hospital and you did blood work, for example, it's going to be there. If you did X-ray, you did an MRI, it's all there. So you don't have to walk with a file, you don't have to walk with a flash drive or a CD or say, I don't even remember when that happened. Okay. Once they have your information, all your information follows you.
Okay. Well, I'm going to be hawkish on you all to move that along and move it along quickly. Yeah. So that's good to know. And I'm sure that the general public, not knowing that, would be a little bit more at ease and see exactly the direction in which we are going in terms of improving the quality of healthcare services. And what was important too that you mentioned, everybody will be trained with this evidence. Yeah. Hence, it's 8 or 10 or whatever folks are going across, whether it's pharmacy, radiology, even the trade
finance. We have finance coming. We have the lab. We're looking at what it is really is the conference allows you to see the end users. The conference isn't necessarily about persons pitching something. It is actually the end users, the doctors and nurses, the pharmacists. They're there presenting, this is how this works. You can literally go in and ask a question. You can even come up with your own questions for them. For example, we went there and we had some issues with like currency, changing the EC to US. They have they call it think tank. You can go to the think tank and ask this question, and if they don't have an immediate answer, they'll get back to you with what you need to do or how it can be done. And it's actually helpful because you're actually able to speak to your peers. So the question isn't so far-fetched, or you're not feeling like you're asking a dumb question because somebody else is there that may have a similar question to you. And one of the things I like about TrueBridge is the fact that it's tailored for rural and small hospitals. So these aren't big hospitals. There was actually one hospital that had 3 beds that made Angola look huge.
Okay. I see what you're saying, and that makes sense. Because we're not a Jackson.
No. Not Memorial.
Not Columbia.
No.
And stuff like that. So stuff that is tailor-made. That is interesting and really a breath of fresh air going forward. Again, we're talking about training and exposure. You and I would have attended at the Miami Conference Center, I think it was sometime last year.
Yes.
Where we were exposed to just about every piece of medical and health equipment from throughout the world that was there. It gave us a pretty good idea as to what is out there and so on. And we were able to have discussions with Philip as well as GE.
Yes.
But I would have said it here on this program before, I'm not bashing, the MRI machine that is there. We didn't have anything before, but at the end of the day, it is better than nothing. And we are going to improve what is there, even if we have to replace what is there, so that we'll be able to have that services that are available to our people. So I'm not going to go down that route in terms of what we would have discovered there from the makers, the manufacturers of it as well. Going forward, there's a list that I have here of some more than $2 million that we would have invested in equipment and so on, imaging and other bits and pieces of equipment. But before we get into that list, the mammography equipment that was purchased, where are we with that? And where are we going to install it and so on?
Sure. So one of the things we recognized that we hadn't done very well in the last few years was primary healthcare and preventative healthcare. And so we've started down the road of doing more primary and preventative healthcare. And so mammography is one of those things that we're seeing is a need for people on the island. That's actually going to be installed in Welch's. The machines are already made. We actually have a representative from GE coming in next week just to confirm and verify the findings, because we have to have certain requirements to get the machine in. That'll be done next week. Once that's done, we're probably about 3 to 4 weeks out before we have those machines on island. But they're built and ready to go. Grateful to you, Mr. Rogers, for getting the donation for that. That's a little over $500,000 in equipment. But early detection, I think, will be, it's one of the things we heard when we spoke to the other hospitals about patients being transferred from Angola, that that we need to do a better job of early detection, a better job at the preventative and primary care. And so we took that lesson, we took it in the face. It was not an easy thing to hear, but we took it and we decided, well, with your help, that we would be able to do something different and move it forward. So for the first time, we will have mammography within the government system.
Yeah, for the first time.
For the first time.
There's always a beginning, and we are proud.
Okay, so mammography is for breast cancer. All right, so we've been seeing on I think the last conference we went to in Bermuda, they were actually looking at how we can be better prepared to deal with our healthcare issues in the Caribbean. They're saying that Caribbean people are predisposed to certain cancers. Prostate cancer in men.
Yeah. Big. Absolutely, big time.
And then breast cancer in the females. So we have a prostate cancer program started, it's running. And so what we're lacking is for breast cancer. And so we decided that the time would be now to make that investment. We did not want to put it in a place where we had a whole lot of traffic. We're trying to build out our clinics, as I said. So in the future, you will see dental return to Welch's. Okay. We have dental at South Hill. So we'll have basically dental in the 3 areas, and then Welch's will have mammography. Okay. We're also looking at putting the ultrasound over there as well. Okay. So we will be able to take that burden off the hospital. So if it's not an urgent or immediate ultrasound, shortly you'll be able to do that at Welch's.
Yeah. And the thing about it, again, it all ties into the evident and the telemedicine, so that if you do your mammography screening up at Welch's, and you see a physician down at Western, you'll have all the information.
All that information is right there.
Coming up. So it's a lot of,
in real time.
There are a lot of criticisms out there, but we're moving in the right direction. We're taking baby steps. You did mention thanks to me, no, it's not about me really. It is about improving the quality of healthcare service, and I have dedicated, the next 4 or 5 years and the rest of my life to make sure that whatever I can do, whether it's in government, in politics, or anywhere else, to try and improve the quality of healthcare services. Because we mentioned with respect to the interviews and folks are staying at home. This is home for me. I've traveled nomad all over the world. And those of us who have traveled, you can't compare, let's say, even a compensation that you will make here.
Right.
The fact that you're home and you're making some little thing and you could,
Content
at least
with that.
survive, you're home.
You're home.
So there's priceless, at least for someone, like me.
The
But
thing though,
going
Mr.
forward-
Rogers, is I think that one of the things that we hadn't done, and it's not a this government issue, it's a thing for Angola to look at in general. We've got to be able to replace these equipment. We've got to be able to stay with the emerging technologies. We've got to continue to advance the technology that we have in Angola, because we can't just take the image that we're small and we can't afford or we shouldn't have, or that should not be. But the reality is that, like your smartphone, the technology changes every year. So Angola's not in a position where, and I said thanks to you simply because these are major investments. We're not going to be able to have $500,000-600,000 to put into that set of equipment again next year. Next year we'll have a different set of priorities.
You see,
But the reality is we've got to keep upgrading and we've got to keep moving forward.
but the thing that I want to point out here, is that, with the equipment that that has been purchased so far, it is important to stress that the equipment is absolutely new and emerging technology.
That's right.
And they are covered,
Yes.
parts and labor, for 5 years. So in other words,
As well as updates.
the updates
That's right.
that are there. So yes, we thank those who would have donated used equipment and so on and so forth. And that's fine in larger countries. We have a network of engineering and support staff and so on. Here, we don't have
We
that
don't have that
capacity.
luxury,
And as a
no.
result of that, hence the 5-year upgrading and parts and labor and stuff like that, so that we'll be able to make sure that we'll have that continuation of our services.
And that was one of the selling points for GE.
Those large equipment companies and manufacturers, they don't like the equipment to be down now.
No.
There's a thing called downtime
No.
and turnaround time.
Right.
So but we're working, moving forward with respect to that. Now, in any healthcare institution, service is what you're serving
Right,
the
public.
patients and the public and so on. I got to ask this question in terms of the ancillary staff. The ancillary staff, those folks who do the laundry, the cooking, and so on and so forth. I am convinced that we need to be able to under short-term training, to set up some synergies with various hospitals, whether it's in Antigua or St. Kitts or St. Lucia, some of the islands that are around here, St. Martin and so on, so that one or two of the individuals who would be, in those positions, to go and just, whether it's 2 weeks
Right.
or 3 weeks, to have a look and to see exactly, how they do things and so on, have a different perspective. Because we here in Angola, we tend to do things the way we've been doing them, and when changes come around, we figure, well, hey, that's not going to work.
Yeah.
And we also, have a tendency to think, I would say, lesser of the folks who are actually so important than, let's say Dr. Richardson and so on and so forth. But Dr. Richardson, our surgeon, can't use the operating theater unless it is sanitized and it's clean.
That's
So
right.
as a result of that, I will make sure that provisions are made for those individuals to be able to have a different perspective. Again, in terms of sanitization, cleaning of the hospital. You know, there are various types of chemicals now that are used. And Doc, you would know in chemistry, you mix certain things, and you know,
Create a
there's,
bomb.
you know. So I think those sort of things, in terms of a policy that we've got to put in place to make sure that everybody within the entire system has that exposure and the training. You know, culturally we look at doctors and lawyers and those folks, you know, as if they were, you know, and so on. And then we look down to a certain extent. That's a fact on, you know, some folks. But if the toilet don't flush in a billionaire's home, he doesn't know how to get it fixed. You know what I'm saying? True. So everyone, you know, is as important as the other one. So within the mix, you know, we've got to look out for those folks as well. Another thing that I want to talk about, and Doc or Mr. Webster, you could chime in on this. We were able to visit Occidente in Colombia.
Yeah.
In terms of your experience, Doc, in terms of what you would have seen there, because a lot of patients go to Colombia, and they have been going for quite a while.
Right, they've been going for quite a while. Actually, our neighbor St. Martin has been sending persons there for even longer than we have. And have had formalized agreements with Clínica de Occidente from
eons.
For a long time now.
Yeah.
So
ever since I was a minister.
So we went down there as well, relatively new kids on the block.
Right.
In terms of using their services, and it was actually pretty impressive what they have started down there. They have various agreements with the hotels around. So even for persons staying in a hotel, if the person at the front desk dials a particular code, that goes directly to the rapid response team in the hospital, and they come right over, and they're right next door. And in terms of the technology they have, that was actually also impressive.
Yes.
So they have, I think they were supposed to get a 5 Tesla MRA.
Yeah, the first one in the region.
First one, I think, I can't remember when they were supposed to get it, but
it's supposed to be there now. It's supposed to be
probably there now.
April.
Right, but
April.
right, and they had a number 3 Tesla. They had MRIs. They had
5 MRIs in total, 10 or 15 CT scans.
And just about every specialty that you could
every
think about.
specialty. They had 400 doctors, and 3,500 staff in total.
Right, and what was impressive was, at least from what we could see, and we could see patients that were staying in the hotel with us, and you would have nurses come into the hotel,
On a regular basis.
you would see them reaching out to them. You would see the experiences that they created for the patients. They would take them on excursions. So, you know, it looked like they have a good package, and the way they approach sort of the patient more holistic, well, not more holistic, but holistically, is really, it was really commendable. Now, does that mean, again, everything was perfect?
No.
Probably not. Persons will always have issues, with things, and I encourage the persons that did reach out to let them know, because they seem to be interested in trying
Feedback.
to fix where persons find problems. But from what I saw, I said, you know what, if I had to go somewhere, I wouldn't mind going here. I would. In fact, the area that I was in, I would like to visit again, just to go and see a bit more.
You mentioned something interesting there. You know, whatever the issues are in terms of you know, the challenges and the expectations and so on, they are willing to sort of work with individuals and address those challenges and stuff. That is something that we've got to set up from our only 24-hour facility and the clinics as well, whereby, you know, individuals who may have grievances one way or another, so that they will be able to, you know, whether it's a comment or a Dropbox or something where we could, you know, sort of get those things and address them as we go along, because that's, in terms of improving, we've got to listen to what the experiences of others, so that we'll be able to deal with that.
We're actually putting something in place for that now. The Healthcare Relations Office, and I met with them last week. So we're actually looking at rolling out a new survey which They will do for both the community and the hospital, so that we could look at some of our weak areas, our areas for improvement. So we are preparing to get that done.
Well, you all can just imagine the calls that I get. I mean, I don't even think from a chair in the ER to toilet paper and running water.
Right.
I get it all, but it is important.
It's important.
It is.
Nothing is perfect, so whenever it is that persons have issues, I think we need to be open to listen and see how we can address what the issues are. Some things may be able to be addressed immediately,
and then some not
things, not so much, but the idea is that you would want to have an idea of what path you want to take, where you want to go, where you can improve things, because like you say, you're not going to get everything right, there's always room for improvement.
Always.
So how do you improve things? So that's the only way you're going to do is by listening.
And even again, from a training standpoint, the soft skills training, that's a program that is being worked on.
Yes.
And it will be through the Anguilla Community College. Every single healthcare worker, will have to do it. Of course, it will be staggered, and basically it's, it's hospital, hospitality, health. They all, sort of come from the same stem or trunk, so to speak, And again, when I was doing some of the allied health courses, they said, one lecturer said, hey, healthcare is 80% psychological and only 20% medicine. And the approach that a patient would experience initially, it doesn't matter how much good medicine you practice in the back, that is what they remember, the way how you deal with them, the way how you speak to them. And us as Anguillians, sometimes we become physicians and specialists and, at any given moment, and quickly, without any sort of training. But be that as it may, we still have to understand from a patient standpoint, the family standpoint, how to deal with them and so on and so forth. And a lot of times, the healthcare professionals, they're human beings, and a lot of times they're stressed to the limit. That is the reason why I started off early talking about staffing. There's some people, if they're tired, they snap.
There's always two sides to every coin, and part of that, yes, we have some square pegs and some round holes. We have we have a lot of things that we got to fix.
Oh yeah,
but we accept that, and we're going to try to do our best.
We can't run away. We can't run away from it. No.
But like you said, Mr. Rogers, part of the issue is not having, and basically we have people that are working 24/7, 7 days a week. You're in a situation where you're paid for 5, you're supposed to be at home to get your rest, or whatever, but you're still the person that somebody's going to call. Your church, your home, your wherever you are, your mind shifts back into work. That work mode is almost always on.
But I know about a year ago, in terms of the nursing, the cadre of nursing and the shift system and stuff, there were a lot of nurses that were doing a lot of overtime. I mean, just
more overtime than regular hours.
They're just burned out, So I'm pleased to know that, you said Nurse Haywood would be able to think, but there have been positive experiences going forward in terms of getting the adequate staffing in place and so on, because that's where we start from. You get the staffing, then you got to train them.
Yes.
Whether it's you get trained staff that you would have recruited, that soft skills training basically is absolutely necessary. How you're dealing with it. Another thing, there's so many things that I got to talk about. I'll have to bring you all back along with Nurse Haywood as well. The oxygen plan, that was a project that was I think donated by the OECS. And
True direct relief, yes.
Yeah, and I know that because I go to those meetings, OECS, PPS Health Ministers meeting, and they were very impressed with the delivery of this project here. It was one that they use as a template in terms of the timing, the completion, and so on and so forth. Hence, I think one of the folks from OECS came down to the actual opening of it and so on. Tell us about the capacity there and where we are in terms of, let's say, pipe oxygen, through the hospital.
Sure. So for the first time in probably about 20, 25 years, we have piped oxygen running through all the hospital, inclusive of the wards and the operating theater. The project was done through OECS and Direct Relief. It was a grant. I wrote for the grant along with Ms. Kenesha Charles, my biomedical engineer. We got the tip from Ms. Twyla Bradshaw about the possibilities of OECS sponsoring a project up to $250,000 US. So we decided piped oxygen would be best. The plant now we had a small plant before that we were using. That plant made 10 bottles in 24 hours. These plants that we have now, we can make 100 bottles in a day. It's far different because when we first bought the small plant, we hadn't had COVID yet. 10 bottles a day for the hospital was fine, no issues. Since COVID, we've had a lot of respiratory issues. So whereas the plant was making 10 bottles a day, we're going through 27, 30, 60 bottles, and that's every day. So we're always in a situation where we're running to make oxygen, and then we're looking at the local suppliers to still provide us oxygen as well. So it was just not best. And then we also had issues with persons moving the bottles, the issue of lifting the bottle, transporting the bottle, all these other issues we tried to take away with just dealing with the piped oxygen. So we decided, okay, we're gonna get this plant done. We were actually under the gun because we finished the project in roughly about 9 months. By the time we got the approval and by the time we got things together, because it still had to run through a procurement process. It still had to go through steps. It wasn't like a matter of, okay, you want a plant, we're gonna buy a plant and give you a plant. There were times when we had consultations, and we actually had a gentleman come in just this past weekend. We walked because we had some issues where noise was a concern. So we built a little buffer so the noise does not become an issue. We try to make sure that everything that we have is, we don't want any leaks, we don't want to have any slippage or any issues. And the acting director of facilities, Mr. Harrigan, reported today that since we've put the plant on, we actually have a buffer of 50 bottles. The plant hasn't run in about 9 days. And that's with full piped oxygen to the hospital. That's a far different scenario than running an oxygen plant 7 days a week, 24/7. So you think of how much we were consuming in power, how often the machine would break, or we'd break a belt because literally the machine never sat. It was always hot. The only time we were sitting, the machine was changing bottles, which is an hour.
That older machine that was producing 10, I could remember that a long time ago.
Yeah.
That we had that there, going forward. OECS has always been there. The PPS, the pharmaceutical procurement section of it, that's another one. I could the challenges that comes with that.
Yeah.
But we're not going to touch that this time around. What is the next step, or is there a next project that OECS is looking at in terms of the hospital?
Well, actually, we asked them, and we've written to them formally for central sterilization expansion. Central sterilization, everything in the hospital is sterilized. So we sterilize for the hospital and the clinics. That's all the instruments, whether it's dental, surgical, what the doctors are using, accident emergency. We sterilize everything. That is obviously to prevent infection. Now, the difficulty that we had is that we have central sterilization, but we have one of each machine. So we have one washer and then one sterilizer. We've realized that we've had issues where our sterilizer would go down, or the washer would go down, and we would not be able to meet the demand of what is operating theater and what is dental. Thankfully, we have very good friends in Hughes Medical Center, and they will be able to help us out. But what we want to do is to build that redundancy in the hospital. So we want to expand the existing sterilization unit. We want to double the equipment that we have in there, so we always have a machine available, one resting, one in use.
And in terms of the pecking order and importance, where is that on your list? The reason why I ask that is because, while we commend and appreciate, the services that we would have down at Hughes when one of the machines go down, taking into consideration that we are the only
24/7.
24/7. We cannot put ourselves in that, back ourselves in a position like that. So, hence my question: where is that in terms of the pecking order? Because that is supposed to be right up almost to the top. If we are going to improve the quality of healthcare services and so on.
For sure. We have a lot of projects. We are grateful for the fact that we were allocated $11 million for our capital budget. You can see we've spent $2 million. So we're trying to make sure that.
Well, let's get it. I was never good at English, but numbers. When I say 2, I'm talking about 2 million US.
dollars.
When you say 11, is it 11 US? 11 million US?
No.
Well, you see what I'm saying?
Right.
So let's not
Let's not muddle it up.
Yeah, 2 out of 11 isn't too bad.
No.
But that 2 is actually 5 out of the 11. So
Right.
that's
I got 6 left.
Different.
you see what I'm
So-
saying? It's a lot of work.
What we're doing, there are multiple things on that list, and I can tell you what they are. I already spoke to central sterilization. We have the second orthopedic theater.
I just go to
right.
ask you that, but go ahead.
No,
Give-
so
give us-
I'm gonna get them for you. So the operating theater is next. Actually, the operating theater and central sterilization.
the second operating theater, because there's
Second
a main
operating
one.
theater, yes, and central sterilization are actually happening at the same time. We just got equipment for the second operating theater about 3 weeks ago. We have the technician on the ground yesterday. He's coming into the hospital tomorrow, so we can begin to unbox and look at what we have. We also have a gentleman coming in to do the laminar airflow, which is to ensure that the surgical air is clean, basically. That's going to be starting tomorrow. They're on island tomorrow. In addition to that, we have the morgue, which we built back in 2021. It hasn't been used, so I'm getting ready to have that commissioned. So that's being worked on as well. We were looking at possibilities of replacing the MRI this year quickly. And then we want to look at, we had from tourism had asked about the hyperbaric chamber.
Hyperbaric chamber.
So we are looking at what that could possibly look like for us, because there are different alternatives. And as you indicated, the other major project that's looming would be the design and concepts for the new hospital.
Yeah. But going back to the second operating theater,
Yes.
and the laminar flow and stuff like that, in terms of the equipment
Yes.
that you would need, laparoscopic tower,
Yes.
is on island.
It's
or
on island.
Will be here.
Yes.
The C-arm is on its way, or
The C-arm is
has
built.
been paid for.
And they are now, the C-arm is built, it's actually ready to ship, they're just waiting on the final payment.
Yeah.
The C-arm and the new ultrasound
Right.
are actually built and ready.
Yeah. So basically, that second theater, we'll be able to do orthopedic surgeries.
Yes,
We're going to look at it in terms of ophthalmology.
ophthalmology, right.
We're going to look at it in terms of if you have, multiple surgeries that are necessary at any one point in time. There's a number of things that we'll be able to do that.
Right.
So once we set up that theater, you'll be able to do joint replacement.
Might even be able to do spine.
Yeah. And hence, we'll have to make sure that we have an IC, a functioning IC,
Right.
and so on. So it's all coming together.
Yes.
I have no doubt that in terms of the equipment, that we're going to be able to source them and pay for them. And I have no doubt that in terms of the getting specialists, visiting specialists, and so on and so forth, we're going to get that done.
Yeah.
We are actually, I was asking the CMO the other day, she's looking for that legislation in terms of the registration of our medical professionals. It's archaic. I guess I could take some responsibility for that as well, because there's a piece of legislation that has been around for quite a while. It's probably gotten a lot of dust up on the shelf and so on, to modernize that so that we'll be able to have those visiting specialists come in. You'll have a theater that is available. You have the equipment in there. We have some IC services. We'll also have some physical therapy
Yes.
services as well to go along with it, and so on and so forth. And I say, baby steps. We're
Right.
taking baby steps, but I
Don't forget dentistry.
that we're
Because
moving
we're
into.
making a big push in dentistry.
Yes, yes. I had that there as well, the dental stuff there,
Yes.
to improve the quality of dental services in Anguilla over time.
Right.
Like I say, so much that we have to talk about. But before I let you all go, I put together what I call a healthcare transformational team, because people out there are saying, hey, wait a minute, you had the health authority. The former administration would have dismantled the health authority and created the Department of Health Services. And I think it would be irresponsible because the former administration did something, for us to go back and reverse it. So hence the purpose of putting together this healthcare transformational team is to look at both pieces of legislation,
Right.
and at a wider view with respect to crafting a piece of legislation so that we'll be able, right, to mitigate and avoid some of what I call, the trappings
Right.
of government and civil service. Is no news to you in terms of the issues that we have from a healthcare perspective,
Right.
in terms of the procurement, in terms of HR, the employment, how you employ, the time that it takes in order to get these things through. You don't necessarily have to go back to the health authority in order to do that. Probably, an amendment to the Procurement Act, and you include something in the Department of Health Services whereby, you don't follow the general routine of public admin in terms of, hiring and so on and so forth. And then another aspect of it in terms of the financial management of the Department of Health Services, so that there is a direct link between the Ministry of Finance with accountability and so on, and response to the needs of healthcare, rather than going through all sorts of hoops and hurdles and those sort of things. Because that is the frustrating part for me. And I'm sure that is, well, the dog doesn't have much hair, probably dropping out. But at the end of the day, that's a frustrating thing, and we have to address that, going forward. And there are ways and means to do that. It has to go to Executive Council. I intend to take it to Executive Council next week, really, so that we could formulate and put that committee in place and get them to start working. It's not something that is going to be 2 years or 3 years. I think it's either 4 or 6 months that would be required in order to have a look at these pieces of legislation and come up with recommendations so that we could we could move forward. Like I say, healthcare is everybody's business.
That's true.
And it's apolitical, because at the end of the day, it doesn't matter who you support or which government is in office. People will get sick, people will need care. And it is necessary that we are able to at least improve the quality of healthcare delivery in Anguilla for all our citizens, whether it's the children, whether it's the adults, and so on. And I must say, I'm working on with the ministry, individuals in the ministry, looking at the senior shield and junior shield,
Yes.
because it's not going to go away. We have to improve it, and we have to expand it, so to speak. Just having a discussion today with some of the folks from the Ministry of Finance and the Ministry of Health, whereby it's no secret that the senior shield, as it is today, is limited because it pertains to government, the Department of Health Services.
Right.
And as I mentioned earlier, in terms of the problems with the PPS, the Pharmaceutical Procurement Services, there's no doubt that at government facility, at the pharmacy, that you run out of medications one way or another through no fault of their own, so to speak, but because the pharmaceutical procurement system on services under the OECS, that in and of itself has some issues, because you have St. Louis, you have all the OECS countries, they all have
A portion to pay.
an account in the central bank, in St. Kitts, and we all have to, every government has to replenish that and so on and so forth. And from time to time, folks are tardy, and as a result of that, because our orders and consumption are small compared to the other OECS countries. I think the only one in the OECS that is smaller than us, I believe, is Montserrat. All the others, they are larger and get more attention and so on. But that is something that I'm actively involved in and trying to work out so that we can have a better, supply of drugs and so on. So, and the shield is only for the Department of Health Services.
Yes.
Now, if you're 70 and over and you go to the Department of Health Services facility,
you're good.
You don't have to, you're covered.
Right.
However, in the case where, let's say medication, for example, you don't have it at the pharmacy, at the hospital, you still have to go to the 2 private pharmacies and you have to pay 100%. Because the shield is not recognized there. So that's a discussion that we are advancing. We are moving forward with that to have that sort of conversation whereby at least if I am over 70, which I soon will be, and they don't have it at the particular medication at government pharmacy, and I have to go, let's say, to Paramount or Sunil pharmacy, at least rather than paying 100%, for a 72-year-old, they probably pay 10 or 20% of what the cost is.
Right.
That is a significant help,
Yes, definitely.
in terms of getting stuff. So those are the things that we're working on. And as you mentioned, there's another program that I'm working on for diabetes and hypertension with some private donors and so on and so forth. So again, let me thank you all for the work that you all have been doing. There are a lot of criticisms. Of course, we take the criticisms as they are. We try and learn from them, and there are a lot of positive things that are taking place. But we'll continue to chart the way forward. We'll take the negatives and try and improve, and we definitely will have to address some of the issues that you all would have discussed here this evening, going forward. I'm going to have you all back again, and so that we could talk about a number of things that I have here jotted down, and going forward. I'm saying to the general public and to the civil servants and to, the deputy governor and whoever else responsible for the civil servants, that this program, Just the Facts, is what it's about, just the facts. And I think it is incumbent upon us as representatives of the people to be able to inform and educate our people as to where we are and what we are doing in the various departments. So I thank you all. You all are trailblazers. 2 civil servants, senior civil servants, who would have appeared on Just the Facts for the first time in the history of Anguilla. You have civil servants that are on who are not political. Doc, are you interested in the politics?
Not at all.
And I'm sure that Mr. Webster probably will say the same thing, not me. Okay, so as healthcare professionals, we're going to continue to work together to help improve the quality of health services. And I would say to you all, have a little patience with me because, sometimes I can be rough around the edges, especially when I want to get things done and the paralysis of analysis start to, set in, So thank you all very much for being on the program, and to thank you all for listening and viewing. This was another program for Just the Facts.
Thank you.
Thank you.